talked about how to get them positioned within the room optimally so that we can have a lot of success in our first procedure. So the first component that I'm going to talk about is our vision cart. It's a lot like the video towers that you have in a laparoscopic room. The neat things about this vision cart are that it utilizes a really fancy camera. In particular, a 3D HD camera with a 60-degree field of view, a 16:9 aspect ratio, as well as a 5:4 aspect ratio, and 2 levels of digital zoom, which magnify our image 2 times and 4 times. Now, surgeons and OR staffs typically really appreciate the digital zoom feature because it can enhance patient outcomes. It does that by allowing the surgeon to zoom in really close to his or her target anatomy without moving the scope so close that it has the potential to clash with instruments that are used during the procedure. So does that make sense to everybody, how that might enhance patient outcomes if we're able to better visualize the anatomy? Great, let's move on. So another thing that I'll talk about is the endoscope that attaches to it. It's available in 12 and 8.5 millimeter versions, and it has a really neat feature called an RFID chip. Now, for those of you who've worked on the S system, you're going to really appreciate this because you're not going to have to go up on a menu somewhere and explain and select what type of scope you're using and what type of scope angle. This RFID chip will automatically communicate exactly what type of scope is attached to the camera. So other neat features, when compared to the S system, we have a larger, widescreen, touchscreen monitor. It's 24 inches, and it's from this monitor that we can access some really exciting features like Tile Pro, which allows us to access images from ultrasound, EKG, etc., and we can pile them across our screen, much like some of your TVs at home have a picture-in-picture capability. This can really add something for a surgeon who wants to be able to consult an ultrasound image or some other image as he or she is doing surgery. The next thing that I want to talk about is the core right under here. This is the central processing unit, and this is where we make most of our system connections. Now, when we position the vision cart, it's going to be located outside the sterile field, but it's going to be connected to both the patient cart and the surgeon console by our system cables, which we'll talk about here in a few minutes. It's important for us to understand that there's a 15-foot power cord that needs to be plugged in to a dedicated circuit. There's also a 4.6 meter or 15-foot camera cable. So obviously the vision cart needs to be placed close enough to the patient cart so that the camera cable extends as far as it needs to extend. Any questions about the vision cart? Okay, great. Let's move on to the surgeon console. So it's here at the surgeon console where all the magic happens. We have our viewport where our surgeon is able to access our 3D HD image. And we talked about the benefits of that for a patient in particular. The surgeon's going to have a better view of the anatomy than he or she ever has. In particular, they're going to have a greater sense of depth perception when they're working through the tissue planes and dissecting in tight spaces. The master controllers mimic the surgeon's movements and translate them to the various instrument arms that are controlled by the patient cart. And they utilize 2 really exciting features. One is called motion scaling, and the other is called tremor filtration. Motion scaling helps the surgeon to be more deliberate during surgery by establishing ratios of movement. By that I mean the surgeon moves 3 centimeters, the instrument arms will move 1 centimeter. There are various levels that the surgeon can set depending on how deliberate they want to be when they're performing that procedure. Tremor filtration does exactly what it sounds like. All of us have a slight bit of tremor when we move our hands, and this is just going to ensure that only those deliberate movements are translated versus any tremor that the surgeon might be experiencing. There's a touch screen panel that allows the surgeon to calibrate the endoscope. There's also a foot pedal down here that allows the surgeon to move the endoscope autonomously. So the surgeon is going to have complete control of the endoscope. What that means for you, Mr. Scrub Tech, is that you're not going to get yelled at by the surgeon asking you to move the camera here, move the camera there, can you pull it back, can you push it in. The surgeon's going to be responsible for putting it where he or she wants it. Now you'll notice that our Da Vinci Si surgeon console is ergonomically designed. And if you're used to the S system, you'll notice that we can refine the ergonomics in much greater depth. In particular, we can raise and lower the level of the stereo viewer, we can raise and lower the level of the armrest, and we can move the foot pedals in and out via a motorized drive. We can also adjust the tilt. And we have surgeons that tell us that working on the Da Vinci has extended their career by 10 years, which means more time for them to leverage their expertise for the sake of patient benefits. Now, like the Vision Cart, the surgeon console is located outside the sterile field. It has a power cable that runs 15 feet. When we position the surgeon console, we always want to make sure that we apply the brakes so that it's not likely to move during surgery. When we do move the surgeon console, we want to make sure that we only do that by holding onto the handles that are positioned on either side of the armrest. Any questions about the surgeon console? Okay, let's talk about the patient cart. So the patient cart is the component that delivers two really exciting features. The patient cart delivers two really exciting features, and when it starts up, I'll be able to show you.
I think you just powered it down, Josh.
I just oh, did I power it down?
I think so.
One of which is called remote center technology. Now, everybody notices the black band on this cannula. The Da Vinci establishes a fixed point in space around which all of our instruments and cannula move. The reason for this is so that we can be sure that we're exacting very little trauma to the port side. In fact, patients who experience Da Vinci hysterectomies that have both Da Vinci ports and an assistant port where laparoscopic instruments are used often complain that the pain from the assistant port greatly exceeds that of any pain associated with the Da Vinci ports. And I'll just show you really quickly how that works. You'll notice that I'm going to hold my fingers, and as I move this arm, my fingers stay in the same place. Somebody want to come and try that? Jason, why don't you come up? Put your fingers on this port. So are you noticing any pressure on your fingers as I move this around?
Pretty fluid motion.
So this is going to help us provide minimally invasive surgery to patients, and afterwards they're going to experience less pain during recovery. The other key value proposition that's delivered by the patient cart is what we call endo-wrist instrumentation. And what that means is we have instruments that deliver 7 degrees of freedom. So typical laparoscopic instruments will move in and out, up and down, side to side. These instruments, once they're inside the patient, will also move close to the distal tip, left to right, up and down, and then they close like laparoscopic instruments. The result is this allows surgeons to work around structures that would otherwise inhibit them and allow them to achieve angles when going across tissue planes and vessels that allow them to achieve the maximum benefit for their patients. So definitely a large step forward for patients in terms of the quality of the procedure that we can deliver in a minimally invasive fashion. Now the patient cart is located outside the sterile field initially, and we move it forward into the sterile field when we dock the patient cart to the cannula that have been placed in the patient. It has a 25-foot power cord to accommodate the movement that takes place just prior to surgery. In order to do that, there are a few key concepts that we've got to cover and make sure that we understand. So does everybody want to come back here with me? So I've gone ahead and activated the power button. You can see our LEDs that indicate that the power is on. And these are the components that are required for us to advance the patient cart. First, this is our shift switch, our throttle enable switch. The combination of depressing the throttle enable switch and moving our throttle forward will move the patient cart forward. Now that said, there's one other thing that needs to be done before we're going to be able to move this forward. You'll notice up here we have our shift switches. While our shift switches are in neutral, this cart will move freely, but we can't engage the motor drive. So in order for me to engage the motor drive, I need to shift both of my shift switches from N to D. Now, if I press my throttle enable switch and I move my throttle forward,
Cannulas.
the patient card will move forward.
That's a good safety feature.
That is a good safety feature, and I'm glad that came up because it's important to note that once a cannula is installed, the patient card is going to stay stable. It assumes that those cannula are inside a patient, and for safety reasons, it will not allow itself to move, even if we press our throttle enable switch and our throttle. Now, like the other components, the patient cart should be plugged into a dedicated circuit. The difference being that we want to plug in the patient cart 24 hours a day so that we're constantly charging the backup battery that's needed to move the patient cart outside the OR. Now the other thing that should be considered when positioning these various components are other products that are being used within the OR. So by that I mean insufflation, anesthesia, the anesthesia cart, and also other third-party equipment like bear huggers, ESUs, etc. So any questions about the various devices that are located in the OR and where we want to position them relative to one another, how we plug them in, battery backups, those types of things? Okay, so we're going to go ahead and move forward and talk about how to start up and home the Da Vinci system. Great.